Hi, I'm Paul McNamara. I was on the program as Dr. Paul McNamara. I'm not on the CNC. I have presented at Grand Rounds before. In 2020, it was International Year of the Nurse, and I kind of bullied John McBride and Peter Burke into letting me present during International Year of the Nurse. And this time round, it was more a Stephen Bradbury thing. Dr. Janet Bailey, who's the psychiatrist with NQUES, North Queensland Eating Disorder Service, she's unexpectedly away. And so she passed on the baton to Shamila Prakash, who's the psychiatrist on my team. She's unexpectedly away. Sky Murray, who's here, who stepped in to fill Janet's shoes only about a week and a bit ago. And so I got shoulder tapped. I'm reprising a session that I did on Wednesday. It's not quite the same session that you would have got if either Shamila or Janet were presenting. So just going to run through the who, what and how of what we do, and just try to give, for those who aren't involved in the day-to-day care of medical care of people with eating disorders, what we're on about and what we do. So the who bit is pretty straightforward. So Shamila, the psychiatrist, we get 2 fresh registrars every 6 months, and at the moment we've got Owen and Manju, who just presented with us as our advanced trainee, and Yelena and myself, the CNCs. Yelena's trying to hide down the back, but I can see you. About the what, just a bit of data about the what of eating disorders. So in DSM-5, it's got this list of various eating disorders. But I'm pretty sure the most common diagnosis is the last one, eating disorder other, or eating disorder not otherwise stated. But nearly always we see aspects of those top, probably 3 or 4, the top 4 would be the most common sort of aspects. Picker about eating non-food stuffs. Chalk is yummy, so is rubber. That's not very common in this job. And rumination disorder, just to clarify, isn't about the ruminations that we have. It's about actually ruminating like cows and goats do. It's about vomiting and redigesting. And that I've yet to come across that, and I've been doing this job off and on for 20 years now. So lots of anorexia and ARFID in particular. The data from the National Eating Disorder Collaboration is that about 1 in 20 Australians has an eating disorder, and about 15% of women will experience an eating disorder some stage during their lifetime. This isn't reflected in hospitalisation numbers at all. We see a much smaller percentage. It's also of concern is that some data suggests that eating disorders have the highest rate of mortality of any psychiatric illnesses, and particularly with anorexia nervosa, where somewhere between 10 and 20% have an unexpected early death. So it's kind of a big deal that we get it right, and I guess that really highlights the medical component of care for eating disorders. So what do we do on the consultation liaison team? Well, we do consultation and liaison. That looks a bit like this. This is a mock-up of a patient file entry. And on this occasion, we've got Shamila and Yelena seeing the patient together. They give a bit of a rundown of who the patient is and what she's about, what her diagnosis is, of course. But probably the most important part of the session is where we sit down and try to work out what helps and what doesn't help. And in this case, the patient was able to describe, that distractions are pretty helpful. Things that don't help are getting focused on food, and that would be fairly common for a lot of people. We try to find a way to come up with some common goals with the patient, and it depends on where they're at. If they're really in severe eating disorder, sometimes the person you're interviewing isn't necessarily the patient. The eating disorder is taking up all the room in that interview. And that's really hard to get common goals with if the eating disorder is being the predominant voice in the room. So we try to spend enough time to find the person who's being affected by the eating disorder. I'll come back to that othering of the eating disorder in a minute. And then the important part of what we do is the collaborative part or the liaison part. And we spend a lot of time speaking with the patient, and we recognise the luxury of our role. I don't think there's all that many people in the hospital who wouldn't feel that it's unusual to sit down with the patient and speak with them for an hour. We get to do that, and we think it's really important to pass on the patient perspective. Without the patient perspective, there can be empathy failure. Empathy failure is really bad for health outcomes. So we try to pass on what's going on for the patient and liaise with the medical teams and the nursing teams and the dietitians in particular. They're the key players here. And then together in consultation with those people and the patient, of course, we come up with a bit of a plan. We recognise, and I'm not sure how well this shows down the back, but we recognise that we're just one small cog in a fairly big machine. So if you can't read it, at the 12 o'clock position there is my team, Consultation Liaison, and going around, we've got the inpatient dietitian, who's often Emma Coleman sitting over there, the medical team, of course, so Sharaf Bibbin, Sean, the nursing teams. Bibbin's already mentioned Gen Med nursing team. They've been amazing. The difference that they've made, the skills that they've acquired over the last 18 months, it's been had a terrific outcome on patient outcomes, had a terrific effect on patient outcomes. But we're on the inpatient part of the team. In the green bits are the outpatient parts of the support team, and that's where the patient will spend most of their time, of course, in the outpatient scene. And so we've got NQEDs there, the GP, there may be a psychologist or psychiatrist in private practice and or with the community mental health, and sometimes there's other supports there too. And of course, there's the person themselves and their family and close friends. And something that I didn't include on this diagram, and kind of kicking myself a bit, I realised on Wednesday I omitted peer workers. So that's usually people who've got lived experience of mental health problems who support people through. And we had on Wednesday had a really quite moving story about how a peer worker who had overcome her battle with an eating disorder supported somebody else who was in the depths of eating disorder. And turns out, as clever as the rest of us like to think we are, turns out it was the peer worker actually made the difference in this person's health trajectory. So anyway, so we're a small cog in a big machine. What do? We try to separate the person from the eating disorder, and I mentioned before that sometimes the eating disorder takes up all the oxygen in the room, and that can be really difficult to work with. And so to try to help the patient and ourselves separate the person from the eating disorder, we like to other the eating disorder and sometimes even name it. On Bibbin's data, I'm not sure if you caught it there, but it's 45% of the people we've had come through as medical admissions with eating disorders are health professionals, and then another about third on top of that are professionals in other realms. So these people aren't duals. And so we want to be working with those intelligent, smart people, not getting caught up in the arguments with the eating disorder as best we can. And to do that, we like to put the eating disorder over there so we can speak to the person over here. My favourite example of this is a mother and daughter. They'd beaten us to it with separating the person from the eating disorder, and they'd called their eating disorder Regina. I was like, why Regina? And they said in the movie Mean Girls, Regina was the meanest of the mean girls. And that's such a lovely way to think about eating disorder. There's another patient we've had coming through a bit over the last couple of years who has named her eating disorder after a high school bully. And yeah, it's a good way to conceptualise and other the eating disorder and hopefully take some power back. Another big part of our job, of course, is to support the nursing and medical teams. We don't have to invent much of this from scratch. The QEDS, the Queensland Eating Disorder guidelines, are very Googleable, so that sits on the Queensland Health site, so it's not on QEPS behind a paywall, so any of us can find it just by Googling QEDS guidelines. And it's super handy. It's got this table which tells us when somebody should be a medical admission and when somebody should be a mental health unit admission. And I remember when we first saw this table, I think first time I saw it might have been 7, 8, 9, 10 years ago, one of those. And it was such a relief because it stopped all those arguments about who was going to take over care. We could refer to the table and say, oh, they meet this criteria or they don't. And so that's made it much more clear for all of us, I think, and has stopped that little battle about whose patient it is. In this same booklet, there's a guide there for the ED team about what they should be doing. And then once they hit the wards, if they come in as a medical patient, it's got pretty good instructions about what sort of things the medical team should be looking at by way of monitoring and medications and observations and what have you. We try to, the other thing which I haven't included a slide of in there, also in this booklet, in the appendix, it's about when we can use the Mental Health Act for treatment of a mental of an eating disorder. As we saw in the data that Bibin presented, that still pops up about a quarter of the time, third of the time. We try to do it as voluntary as much as we can, but it's nice to know how that works. And that advice is in that same booklet. We translate some of those safety and monitoring things from that booklet and put it in the patient file. That's where the staff who are caring for the patient will be looking. And probably of more use, particularly to the nursing staff, is if we enter them into the orders section in IMR. The nursing teams organise their day off what's in that order section. So if we make the right thing to do, the easy thing to do, that's going to be better for everyone, not just for the nursing staff, but for the patient as well. Another thing I like to highlight in these sessions is with the use of assistance in nursing. And it's really important, not just in eating disorders, but for all aspects of care that we provide in the hospital. Remember that we can delegate specific tasks to an AIN, but we can't delegate responsibility. AINs have a Cert 3, Cert 4 TAFE qualification. They're not registered with AHPRA. We've all got degrees or better, and we are registered with AHPRA. So we need to give really clear directions, and we take responsibility for what tasks the AIN does, and we delegate them. I think what happens sometimes is that the AINs are thrown in the deep end with these really complex patients, the person who just survived a suicide attempt, the person who's got a severe eating disorder, the person who's profoundly confused, and without any instructions. And we collectively need to be really cautious about not doing that. That's a real risk, not just for the AIN and the patient, but also for the organisation. So we try to spell out for the AINs in fairly simple language why the patient's here and why they're here. We like to outline their expectations. I think a really complex thing that we ask AINs to do is around meal support. There's a terrific online education session. It only takes about 30 minutes. I'd recommend anybody looking at it. It's called The Shared Table. And it talks about supporting the person through meals. And it starts off with one of the things they say earlier in the piece is that for somebody with an eating disorder, the prospect of eating food would be like for most of us putting our hand into a jar of spiders. So how do we help somebody overcome that degree of anxiety 6 times a day, 3 meals a day, plus 3 snacks? Distraction is usually the best way. And that's what we're asking these really qualified, underpaid people to help us out with. Can you please distract this highly anxious person 6 times a day while they complete meals? And we try to give them some tips and tricks on how to go about that. And then we come back and we review this plan as time goes on. We give a copy of the plan to the patient and a copy of the plan to the AIN, and we invite both the patient and the AIN or the patient's family, if they've got other ideas about what we should and shouldn't be doing, let us know and we can modify this if it's reasonable. So that's about the documentation side of things. Just the last couple of bits I want to touch on. As you may be aware, the language of psychiatry was all just made up about 100 and 120 years ago. And there's a lot of that stuff about transference and countertransference. Just as a reminder for those who haven't used these words lately, so transference is the emotions and feelings that the patient transfers onto the clinician, and the countertransference is our response. And it's our job, particularly when somebody's got an eating disorder, and they might be quite hostile. The eating disorder hates the idea that we're going to try to make it go away. And so we might get quite a bit of hostility, and it's our job to be kinder and smarter and wiser, and not just fight back with our countertransference. And we try to model that and talk about that with the the other members of the clinical team who are providing care at the bedside. Of course, there will be ruptures and repairs in the relationships between clinicians and the patient, and also between the clinicians providing care. It would be weird if we all agreed with each other all the time. And as long as we recognise that that's going to happen, we try to keep that dialogue nice and civilised, and recognise that we're all playing a part in providing care for the person. Hopefully we'll get pretty good outcomes. So that's everything I was planning to say, and thanks for your time.
Thanks, Paul. Any questions there? Looks like a very structured and sort of standardised setup, which is the whole point of it, I suppose, to try and...
Yeah, and it is. And we need to be a little bit careful about that, Peter, because eating disorders are pretty rigid too, and those guidelines are pretty rigid. And so we need to kind of individualise them a bit. But it's great to have a starting point, and then we individualise it for each patient.
Yeah. All right, is there anything online, Matt? No. All right, well,